Hi everyone, I am doing your Lab Quiz 2 review video. It is just covering the facial bones and sinuses, so nothing on skull will be there, but just keep in mind that all the positions that you learned from skull will carry over into your facial bones and sinuses. You're just moving your central ray a little bit based on the anatomy of interest. I have the test next to me. It is complete. It's 50 questions all together. There is minimal labeling on this exam, nowhere near what the last test was. And there's going to be some image identification and some image critique as well. So again, it's 50 questions altogether. 38 of them are multiple choice, and then you have some open-ended and labeling questions. So let's get started. Get my little pointer, and away we go. Okay, so here's a review of your actual facial bones anatomy. This would be the lateral view that we're looking at, lateral aspect. Right here inside, you can see the lacrimal bone. Now, there are two lacrimal bones, one on either side, and lacri means tear. So that's right where your tear ducts are going to be. And then you can see your nasal bone right here. Again, those are also two of them, one on either side. Your zygoma, also you have two. And then you have your maxilla and your mandible. Over here, if you're looking at the AP view of it, a little bit more of a breakdown. Again, now you can see that the both nasal bones, you can see that there is a symphysis or a junction of your maxillae. So here's your maxilla. Here, both sides, it makes up some of the orbital floor. Your left lacrimal is very dark, and you can see it there. And then here's your right lacrimal on this side. Kind of a bad choice of how they chose to delineate the color. And here you've got your mandible. And this portion of your mandible is called the mental point, the mandibular symphysis, the mentum. There's a few different words for it, but this is your mental point here. Down off to the side, this is the body of the mandible, and then what goes up here are your rami. So if you wanted to talk singularly, it would be a ramus, okay? So this would be your right ramus, and this would be your left ramus. And then it does show you the inferior nasal conchae, but that is not part of the facial bones area, so you can just kind of ignore that. I wanted to put this slide up because it is good for you to realize that some of your landmarks coincide with the junction of your bones. So for example, here you've got your nasion right there. And if you look back, you can see that the nasion is at the same level as where your nasal bones meet. Right? And then if you look at the acanthion, this is where your maxillae will meet or join together. And we'll go back and I'll show you that. Okay. And then, of course, you have your additional landmarks to look at. Your glabella is a huge centering point when you're talking about skull work or facial bones. Your nasion, also a very important landmark, acanthion, your mental point, all important. And then the gonion or gunion, however you'd like to pronounce it, is where your angle of your mandible is. So your gonion would be right here. And then the IPL or interpupillary line is also very important so that you're not getting any rotation of the facial bones, and it would, whoops, went down one. It would be going from literally from pupil line to pupil line, and it would most of the time be either parallel or perpendicular to the image receptor. So those are your body planes and what junctions make up those little landmarks there. Again, we're looking at more of the facial bones. This is just another view. When we're talking about the palate, what makes up the hard palate, you're really talking about the maxillae. They make up the majority of the hard palate, and then towards the back, of your palatine bones are back here, and this is more of your softer palate. So your hard palate is going to be mostly your maxillae. All right, and then this is just an internal view of what all that looks like, your palatine process of your maxilla. Palatine bones are back here. It's just showing you different reasons, your nasal concha, which this we don't really have to worry about too much, but I just wanted to point out the hard palate being the maxillae, and then more your softer palate being your palatine back here. Now, there are different joint classifications. You primarily dealt with the sutures being the fibrous or the thin arthroidal, which is non-movable. But with facial bones, you are dealing more with these next two bulleted points here. So your alveoli and teeth are going to be fibrous. They don't move, so they're thin arthroidal, but they are fibrous joints. And your TMJs, those are more movable. So they're synovial, they can move around, and they're bicondylar, meaning they have two condyles for opening and closing. So bi meaning two, condyles for attachments. So that's what you need to know for your joint classifications for TMJs and for the teeth. This is just kind of a picture of the difference between an open and closed mouth when you're taking radiographs of the TMJs. If you notice here, this is the actual condylar process of the mandible. All right, and here is the open joint space. So here is the fossa and the joint space. So this is an open section. So you can see all the darker or the density here. That's the open joint. If you look on this one, you can actually see the condyles seated inside the fossa here. So this is a closed mouth where the condyle's in the fossa, and this is an open mouth where the condyle is outside of the fossa. All right, sinuses. So there are 4 groups of sinuses. They all communicate with the nasal cavity so that when you get a cold, it is all draining out of your nose, which is no fun for anyone. The only sinus not located in a cranial bone is the maxillary sinuses. So that's something unique just to the maxillary. And if you look over here, the AP and the lateral of your sinuses, you can see a few different things. So here is your frontal sinuses. Those aren't usually ever going to be symmetric, and depending on male or female, they can be bigger or smaller. You've got your maxillary sinuses here, and your ethmoids are the green coloring, and then posterior to your ethmoid, it's just showing you is the sphenoid, but if you were to take an AP radiograph, you really wouldn't be able to determine the sphenoid in that direction. Lateral is where you're really going to see all of the sinuses in one view. So here's your frontal, the green is your ethmoids, then just inferior to your ethmoids are your maxillary, and then in the back here, posterior is your sphenoid. If you notice, all of the sinuses are named for the bones that encapsulate them. And again, the maxillary is the only one that's not a cranial bone. The other 3 are cranial bones. And again, the maxillary sinuses are within the maxilla. And you can check for air fluid levels. They're above the upper teeth. So when you start to feel a lot of pressure in your sinuses, sometimes you can get tooth pain. That's actually a pretty common thing that happens because you can see here's the roots of your molars here. So when all this gets filled with fluid and you have a sinus infection, your teeth start to hurt. Frontal sinuses up here. Inner and outer tables of the frontal bone, so they're just located within the frontal bone. They're not really symmetric, and the number of them can vary. You can have 2, you can have 3, 4, however the little bubbles show up. There's no real rhyme or reason to how they develop. The ethmoid sinuses are located in the lateral masses of the ethmoid bone. So this whole region here is the ethmoid bone area, and then here is the lateral masses that have the ethmoid sinuses. They have 3 collections, and they communicate with the sphenoid, sinus, and nasal cavity. And you can see the lateral view here. Here's your ethmoids again. Your sphenoid sinuses are located just below the sella turcica or Turkish saddle. They are also asymmetric, meaning they don't have the same shape. The real important thing to remember with your sphenoid sinuses is that they can indicate a basilar skull fracture, because where they're located is generally towards the base of the skull, and if there is some kind of fracture in the base, these tend to fill up with fluid. So that's how they'll determine a basilar skull fracture. And another term for that is for the sphenoids filling up with fluid is a sphenoid effusion. And here's just some radiographic anatomy review for your sinuses, and your book nicely points this out, that these are your frontals. This is your ethmoid here by the nose, and your sphenoid right below your sella turcica, which is right here, and then you've got your maxillaria. And again, this is really the only view where you can clearly see all the sinus as well. And here's your PA Caldwell, and you can see here that there's more than two little areas for the frontal sinuses. So like I said, everybody develops them differently, but here's your frontals. Generally, like, you mostly see ethmoid. It's kind of being generous saying you can see your sphenoidal, but you can't because it's kind of superimposed by the ethmoid sinuses. And then here are your maxillary. So when you're looking at a radiograph, the sinuses generally are filled with air, so they're going to look darker on a radiograph. So wherever you see areas where there's darkness, there's generally air. See it going down into the throat region, your trachea here. Here you've got air, so, and then here, back here, you can see the mastoid aerosols. Here's another view, the transoral projection or open mouth waters. This one's important because this is really the only one where you can see the sphenoid straight on through the open mouth. So your sphenoidal sinuses are back here. Your maxillaries are here, free of superimposition of the petrous ridges, which are actually down here now. And this little A here, this is the air cells of the mastoid, and then F up here is your frontals, and E by the nose and the nasal septum is going to be your ethmoid sinuses. This is an SMV. This is another one where you can see the sphenoidal sinuses right here. Your ethmoid sinuses are just anterior to the sphenoid sinuses, and you want to make sure when you're doing an SMV that the mental point or mentum of your mandible is not superimposing your ethmoids. If it's superimposing your ethmoids, you need to extend the neck more so that it gets this out of the way. So that's really important for like evaluation criteria. And then these are your petrous ridges here, your ethmoid air cells here, and these are your maxillary sinuses up in here. But more than anything for SMV is seeing the sphenoidal sinuses, which are closer to the center of the skull, and then your ethmoids free of superimposition of your mentum. Also included in the exam are your orbits, and some things structurally to recall about your orbits is that they have a conical or conical shape, and you just need to know that the posterior region is called the apex and the anterior region is called the base. So here's the apex back here, and here is the base up here. Now, the base of the orbit contains three bones. It's your frontal, your zygoma, and your maxilla, which it points out here. So this is the base of it. And then here is a nice image, which you should really take a good hard look at. Make sure that you know everything on this area in this image. You want to be able to identify the cranial and facial bones that make up the orbit. So let's go through them now. A is pointing towards your frontal. B is pointing towards your lacrimal. C is pointing towards your ethmoid. E is pointing towards your palatine, or hold on, I might be lying. Give me 1 second. I'm lying. You'll only have for the rest of my life. I don't want to be a liar. Okay. So I was correct that this is the palatine. And then you've got your greater wing of your sphenoid back here. And here is your zygoma right here. And this is, G is the maxilla, but also H is the maxilla. So that makes up the floor here. So make sure you know that. So one more time, A is frontal, B is lacrimal, C is ethmoid, D is a greater wing of sphenoid, E is your palatine, that's that little purple section there. F is your zygoma, G is your maxilla, but H is also your maxilla. That's the orbital surface of the maxilla there. So make sure you pay attention to this particular image. There all are also are a few different types of fractures associated with your orbits. There's a couple that I really want you to pay most attention to because these are the most common that you're going to see in the department usually. The tripod fracture, it's called tripod because it's breaking in 3 sections. So that's important. That's broken off into 3 sections. That's called the tripod fracture. The blowout fracture happens when somebody gets hit in the eye straight onward, and you see how it blows out the orbital floor. So that's what the blowout fracture is. So these 2 are the most common that you're going to see usually in the department when you're doing radiographs. That's why I wanted to point them out to you. But you can see here that it involves 3 breaks in the bone area. So this is your maxilla, and your zygomatic bone is breaking away from your maxilla, your frontal, and your temporal bones. Okay. Here is another image that you should be very good at labeling. Pay attention to your waters, make sure that you can label it appropriately. So if we went through all of the labels, A is going to be your, hold on 1 second. Okay, give me 1 second. That's where it needs to be. Okay, so A is going to be your zygomatic process or prominence or zygoma, whatever you want to say. So that's right there. B is actually, I would say this is pointing to your maxillary sinus, but maxilla is also fine because the body of the maxilla is right there. C is the bony nasal septum, which is right there. Excuse me. D is the anterior nasal spine. C right there. E is going to be your zygomatic arch. So this section here, see how it goes around? Here you go. That's a little bit easier to see on this guy than it is on your radiograph, but that's your zygomatic arch. There is no F on your radiograph. The F on your little skeleton guy here is the coronoid process, but you can't really see it here. I mean, if you wanted to see it, it would be located right in this region here for F. Moving on to G. G is your condyle, so the head right there, and you can kind of see it here as well. H, if you can see the little tip down there, the H is the mastoid process. Here it is here. I is the gonion or angle of the mandible, however you want to call it. And J is going to be, it looks like it's pointing directly to the dens, the odontoid process. If you put foramen magnum, that would also be acceptable because this is the foramen magnum, but in the radiograph, it's pointing specifically to the dens. So either one would be acceptable. So a couple quiz me's. Now this is up on your original PowerPoint, so it's no secret. These are up and out, but there are some questions that you should know. So which bones form an aspect of the bony nasal septum? Well, actually two of them do. So that's why I circled the ethmoid and the vomer, because those two bones are making up aspects of the nasal septum. What is the name of the process of the mandible in which the lower teeth are embedded? That's the alveolar process, and those are fibrous joints, remember, so they don't move. They're synorthoidal, and that's the alveolar process. Which paranasal sinus is the last one to develop? The last one is going to be the ethmoid. That usually develops like later on in your teenage years. So you need to pay attention to when all of your sinuses develop. I already told you the posterior aspect of the bony orbit is going to be the apex, and the anterior aspect is the base. That's the big circular opening. And then moving on to some sinuses, or actually, I'm sorry, this is positioning for your facial bones and sinuses. Now, notice the laterals look exactly like a lateral skull. The only difference is your central ray is entering the zygoma. So you're moving the central ray from up here for skull to down here by the facial bones so that you specifically get the facial bones. And notice that the collimation is making sure to get the orbit as well as the temporal mandibular joints. You want to make sure you get the TMJs on there. That's important. And if you're doing all of the lateral facial bones, you want to make sure this one doesn't really show it, but on this one you can see light going over and around the mental point or the entire mandible. So that's kind of important too. Evaluation criteria. C, you want to make sure that your sella turcica is completely in profile. You want to make sure your orbital ridges are all in superimposition. Your mandible is superimposed, free of rotation, so no rotation or tilt, and that you can see everything well penetrated. This is the parieto-acanthial or waters, which if you think about it, it's head above water. So when you're swimming in the water, you would position just like you would keep your head above the water. For this one, it's really important that your mento-meatal line is perpendicular to the image receptor. It's going to exit through the acanthion. And the other big thing, excuse me, I'm choking, to remember is that the OML or orbital meatal line, so your orbital meatal line here forms a 37-degree angle to the image receptor. And this is what it looks like radiographically. So you can see the petrous ridges below the maxillary sinuses. So here's your maxillary sinus, and your ridges are below, so that they're not impeding or superimposing this area. So if the doctor's looking for some kind of tumor or mass or even an infection, it's not superimposed. You want to make sure that there's no rotation, and you want to make sure everything is well penetrated. So you can see your maxillary, ethmoids, and your frontals here. Your sphenoids are superimposed right now by your teeth. Your modified waters is just like a waters, except now your nose is touching the image receptor. So if we go back, notice how the nose is not touching the image receptor. But in the modified waters, the nose is touching the image receptor, and your OML is now creating a 55-degree angle to the image receptor. This one is important because down here it's ideal for orbital fractures and foreign bodies in the eye. So any pre-MRI orbits will be done using the modified waters, and like blowout fractures, if you're looking at the orbital floors, you would want to do the modified waters. And here's some evaluation criteria. Notice how nice and open and rounded the orbits are. And this is why this is the preferred position for blowout fractures, which you would see in the orbital floors, or for any type of foreign body inside the orbit, pre-MRI orbits, if they're looking for metal, because you can see the orbits really well. And I just want to go back and show you. Notice they're not nice and round on the regular waters. They're superimposed, but on the modified waters, they're nice and round and open. And here you want to see for image criteria that the petrous ridges are projected in the lower third of the maxillary sinuses, the orbital floors are not distorted, there's no rotation, and that you can see everything well. So here's your maxillary sinuses, here's your lower third, and these are your petrous ridges right here in the lower third of the maxillary sinuses, and that's for the modified waters. PA axial Caldwell looks very familiar to your PA axial Caldwell for your cranium. The OML is going to be perpendicular to the image receptor. You are still doing the 15-degree angle, exiting the nasion. With that 15-degree angle, the petrous pyramids are still going to fill your orbits. I'm sorry, I lied. When it's a 15-degree angle, my apologies, it's going to be in the lower third of your orbits. Let me just repeat that. It's going to be in the lower third of your orbits. I'm sorry, it's a 0-degree angle when they're filling the orbits. My apologies. So for proper PA axial Caldwell 15-degree caudal angle, your petrous ridges are in the lower third of your orbits. So here's your whole orbit, and this is the lower third. There they are. There's no rotation, and again, optimal exposure factors. You want to make sure everything's nice and penetrated. Typical routine for nasal bones would be a lateral and a waters. Sometimes you will do these special views of PA axial Caldwell or the superior-inferior tangential. This particular one is not on your registry, so therefore it will not be on your test. You will not be tested for this one. So don't even worry about it. We're just going to, no. All right. And actually, let me cross it out to just solidify that point. Not on your test. Okay, now, back to my laser pointer. Okay, so for typical lateral nasal bones, you want to make sure that your IPL or your interpupillary line is perpendicular to the image receptor. The central ray is centered 1/2 inch inferior to the nasion. So you're going just posterior to where your nasion is. You want to make sure that you're in a true lateral, that there's no rotation or tilt of your sella turcica when you're looking at the image. And it's going to enter just about there on the patient. With the nasal bones, you want to make sure, obviously, that they're centered. So your central ray would kind of, here's your nasal bone here, it would just be right there where the nasion is. That there's no rotation, you want it to be completely in profile. The exposure factors is a big one. Because, and I know I've told a couple people in clinical, but with nasal bones, they can get pretty tricky. If you intend to use AEC, which is your automatic exposure control, I would highly recommend against it because it's very difficult to use AEC and get a proper exposure of the nasal bones. If you were to use AEC, you would have to actually center back more into the more bony portion of the facial bones, and then you'd be overexposing the orbits. That way the AEC will hold down. What you'd rather do is do a fixed technique so that you can, center however you want on the image receptor, and the central ray will dictate how much technique is deposited along your nasal bone. So really this should be a fixed technique or manual technique versus the AEC. So that's kind of important fact to know for nasal bones. And of course, then you want to collimate down. We don't need the entire orbit on there. We don't really need a whole lot of facial bones except the nasal bones themselves. Zygomatic arches, the typical routine is your SMV, your oblique infero-superior tangential, and then your apiaxial modified town. You can do a waters and a lateral. Usually you don't, though. These are the primary ones that you'll use for arches. And here's your SMV, just like you saw with your skull work. Your IOML is going to be parallel to the image receptor. That's important. And then this is what it looks like. So the difference between the zygomatic arch SMV and the skull SMV is that is really your exposure factor. So you're not going to need higher KVs to penetrate the skull region because you're actually just shooting for these arches out here, which are very small, very thin bones. So the exposure factors are going to be different from the zygomatic arches SMV to the skull or cranium SMV. You want to make sure the arches are well demonstrated in profile, that they're symmetric, that there's no rotation, and that's typically what the SMV looks like for zygomatic arches. This is your oblique inferior-superior tangential. I know there's a lot of words there, but really it's an SMV. And once the patient is in an SMV, you're just rotating their head 15 degrees towards the side of interest. So this person is turning their head towards their left, and then you're just jutting the chin 15 degrees towards the side of interest as well. So it's a double angle. You're going to rotate and tilt. See, rotate the skull and tilt the skull. The tilt is the chin portion, and the rotate is your head. So 15 and 15. Okay, and then the angle of the central ray is not a particular angle. It's really whatever the patient can do, and what you want it to do is just skim along the angle of the mandible so that it enters just below the arch here. Okay, and what it looks like is this. It throws the zygomatic arch off of the facial bones and it elongates it so that you can see it really well. You want to make sure that there's no superimposition and that it is well penetrated without burning through it or making it look too black. Here is your modified town, epiaxial. You're still tucking the chin and giving that double chin effect so that you want your OML to be perpendicular to the image receptor. If a patient can't make their OML perpendicular, then you could make the IOML perpendicular and then just increase your angle of your central ray to 37 degrees. The difference between this town and your cranium town is where your central ray enters. So this is only going to be 1 inch above the glabella instead of the 2.5 inches for cranium. So 1 inch above the glabella. You can still use the same angles that you saw for your skull work, but the central ray entrance point is a little bit different. And this is what it looks like. And with this one again, you don't need technique to penetrate the skull or facial bone region. You just need enough technique to show the zygomatic arches off. And what the town does is it lengthens them really well so that they can see the body of the arch to make sure there's no fractures. Typical mandible routine is an axiolateral oblique and the PA or PA axial depending on the facility. Very rarely will you do an SMV or a Panorex. Now a lot of facilities have Panorex, but again, Panorex is not on your registry, so it is not on your test. So we're just going to get rid of that right there. Okay, the axiolateral positioning. A lot of people get confused or nervous when doing this in clinical on the floor. Really what you need to remember is how to rotate the patient. So all of these positions of the patient require a 25-degree central ray. So hold on, let me point that out if it'll let me. So it's a 25, oh, why'd they do that, degree? That's annoying. Central ray, and it's going cephalic. This is really hard, guys. This is about what my handwriting looks like a kindergartner did it anyway, so close enough. So that's supposed to be a 2. I don't know why it's doing that. It looks kind of bad, but anyway, 20, maybe I'll do it again. 5. There you go. 25. Let me get rid of this. That looks crazy. All right, anyway, 25 degrees cephalic angle. But what's important is how you rotate the patient. So when you're rotating the patient, if you want to look at the rami in profile, you really want to keep the head in a true lateral, just like you were doing lateral facial bones or lateral skull. And it would enter 25 degrees cephalically into the ramus itself. So the central ray is always entering the anatomy of interest. If you wanted to see the body of the mandible, you would just rotate the patient's head toward the image receptor 30 degrees, still using the 25-degree central ray entering into the body of the mandible. If you wanted to see the mentum, what you would do is rotate the patient 45 degrees towards the image receptor, still using the 25-degree central ray angle entering into the mentum. Most facilities will use a 10 to 15 degree rotation just as a general survey if they're not sure where on the mandible the fracture is. Otherwise, if they specify where it is, then you know as a technologist how you need to rotate the patient. So patient in true lateral is for rami, 30 degrees rotation is for body, and 45-degree rotation is for mentum. All of them have a central ray angulation of 25 degrees. And this is kind of just showing you a little bit more of that. Again, I'm highlighting the 25-degree cephalic angle. If a patient comes in and they're boarded and collared and can't move or tilt for a mandibular fracture, then you can either tilt the image receptor or you can angle your central ray 10 to 15 degrees initially, and then instead of tilting the head back. All right. And here's kind of what it looks like. So you still have your 25-degree central ray. The body is rotated 30 degrees inward. So you have your head rotated 30 degrees inward, and that's to see the body of the mandible, which is here. And this is what I was talking about. If somebody's boarded and collared and you can't tilt their head, you can tilt the image receptor, or you can keep the image receptor flat and then increase your central ray angulation a little bit so that you can fake the angle. And here's more of that trauma position. You can see central ray is still 25 degrees cephalic, and then you're going 5 to 10 degrees posteriorly, and that's kind of faking that tilt action there. And this is really what a axiolateral oblique mandible looks like. They're kind of cool once you get them. They look really nice. So you can see here that the angles are not superimposed on each other. So here's one angle, the body, the mentum, and then here comes the other angle going up this way. The mandible isn't foreshortened, meaning it's not scrunched together, and you want to have optimal penetration so that you can see nicely everything that you need to see on the radiograph. The PA or PA axial mandible, if somebody has a broken mandible, I mean, really, this is so painful to do on the table. You would probably want to do this standing, just to be honest with you. The straight PA is fine, or you can do a PA axial with a central ray angulation of 20 to 25 degrees to see the condyles. What you do with that central ray angulation, when you angle it upwards, it squares off the jaw. So that would be the difference. So here is a regular PA. You can see the jaw, that's ouch. That hurts right there. There's a fracture there. But a regular PA looks like this. I don't have another image with the angle on it, but with an angle, let me try and draw it with my lovely drawing skills. If I had an angle on it, the jaw would be squared off, more like this, and then the condyles would protrude outward like this. So this is why that would be preferred, because the condyles are well visualized and it squares off the jaw. That's with the angle, that 20 to 25 degrees cephalic angle. The regular radiograph, that's pictured here, that's just a regular PA. Apiaxial mandible. Now here's where it gets a little different. So this is a town, but this is a different kind of town because look at your angles. Instead of your 30 and 37, for mandible, it's 35 and 42. So you still have that 7-degree difference. It's just a different degree of angulation. So if your OML is perpendicular to the image receptor, you're going to use 35 degrees. And if your IOML is perpendicular to the image receptor, you're going to use 42 degrees. The other thing that is a little bit different is that you have to remember the entrance point is not 1 inch above the glabella. Now for mandible, you're moving down further, so it's at the glabella. So at the glabella right there. And again, 35 for OML, 42 for IOML. Very important, big difference for mandible. And this is what it looks like. It elongates the jaw. You can see the condylar processes a lot better. They're nice and symmetric, no rotation. You would want probably better penetration down here, and you would obviously want your image receptor to come down a little bit more. This is soft tissue, and here's your skull here. This isn't the best, but if you were just shooting for the condyles, then the penetration is fine. SMV for mandible. SMV is an SMV. Your IOML is parallel to the image receptor, midway between the mandibular angles, and you just want good penetration so that you can see the mandible. Okay, so you can see the entire mandible. Here's your angles, your body, your mentum, your body, and again, your angle on this side. TMJ's routine is going to be the apiaxial modified town, your modified law, your Schuler. Tomography is not on your test, so let's get rid of that right there. These guys are the ones that you will do most often. The difference between the modified and the Schuler will be just whatever the radiologist prefers, really. So here's the modified town. It follows the same guidelines as the mandible. 35-degree caudal angle when the OML is perpendicular, and you could do a 42-degree caudal angle when the IOML is perpendicular. The central ray is going to be at the level of the TMJs, and then just 2 inches anterior to the EAM. That's how it skims across. So that's a little bit of a different feature and unique to the TMJ. The evaluation criteria for the apiaxial TMJ, you want to make sure the condyloid processes and the TMJ fossa are demonstrated. So right here, this is what you're looking for, that black line there. Okay. You don't want any rotation, and you want to make sure that they're exposed well. And I will circle those areas if you're having a hard time, if I can get the pen to work. If you're having a hard time visualizing it, so it's these areas here are what you really want to see. All right. Okay. These are probably the hardest projections for radiographers to remember. I don't know why, we just don't do them very often, but you want to remember with the modified law for TMJ, you're rotating the skull 15 degrees towards the IR. The central ray is going to enter 1.5 inches above the EAM, and then your central ray angle is going to come down 15 degrees. So 15 degrees rotation of the body part and 15 degrees of the central ray. And this person has closed mouth and open mouth. This is uncomfortable for people, so try not to have them wait too long to do the open mouth. This is what it looks like on an image. So here is the joint, and let me just highlight that for you guys. So here is the joint space. Okay, there is the joint space, and this is your condylar process here. This is the joint space opening here, and you want to see the joint closest to the image receptor is what you're shooting for, and you want to do open and closed mouth. This one in particular is closed mouth because the condyle is sitting closer inside the fossa. When we look at the axiolateral Schuler method, also doing the same thing, open and closed mouth. This one, though, you're not rotating the head of the patient. So the head of the patient is not getting rotated. You're just having the 25 to 30 degree caudal angle going into the upside of the patient, and it's going to enter 1/2 inch anterior and 2 inches superior to the EAM, so just a little bit in front of and above the EAM, and you have a greater angle, so it's going to open up that joint space a little bit more. And I just want to go back again. This one's a 25 to 30 degree angle, and I want to just show you the difference. The law is 15 degrees, and this is what the joint space looks like when it's closed. Okay. The Schuler is 25 to 30 degrees, and I really want to point out what the joint space looks like. So I had already gone ahead and circled them for you to visualize, but this is the closed mouth, and you can see how elongated the condyle is, and that's from that larger degree of angulation. So that's from that 25 to 30 degree angle. This is closed, and it's really jammed into the fossa. So your fossa is right here, your condyle is here. And that's what it would look like with a closed mouth Schuler. The open mouth Schuler, you can really see the difference, especially with that larger angle. Here's your condyle out here, and here is this whole open space. See how large that is? That's a nice open mouth TMJ radiograph. So if you could see that really well, here's your condyle, and again, there's that nice open space. Here's your fossa, and that dark area is the open mouth TMJ. So open mouth, closed mouth, and that's the Schuler. Okay. Sinuses, we typically do lateral, PA Caldwell, Waters. I don't really do SMVO that often, to be honest with you, but it is part of a routine at certain facilities. And I have never in my life done a transoral, but I guess you can. I bet you like ear, nose, and throat doctors would probably do this. And then this just kind of shows you that it's important for sinuses. You want to do them erect or using a horizontal beam, meaning that the beam is parallel to the floor, because that way you're allowed to see those air fluid levels in the patient. Lateral sinus, it's literally a lateral again. All you're doing is putting the central ray in between the outer canthus, which is right here, and your EAM. You're just centering like you'd be in the middle of the sinuses, because your facial bones are up here, your cranium is over here, and your sinuses are in between them. So that's why your central ray is entering that way. And again, you can see all 4 of the sinuses on your lateral projection. So here's your frontals. This is your ethmoid, your sphenoid, which is just below your sella turcica, and here's your maxillaries back here. Another position you would do is your PA Caldwell, which is the same thing, 15 degrees, 15 degrees, 15 degrees, okay? You can either have a straight beam, which is a straight PA exiting the nasion, or you can do a 15 degrees, which would put your petrous ridges in the lower third of the orbit, and it would still be exiting the nasion. So that really doesn't change. And this is what it looks like. Petrous ridges in the lower third of the orbits, no rotation. You can see your frontal sinuses really well and your ethmoids really well with the PA Caldwell. So if somebody is in and they suspect sinusitis of the frontals or the ethmoid, this is the one you want to do, the PA Caldwell, so you can see these really well. And then here's your waters. Again, head above water, your mentomeatal line is perpendicular to the image receptor. It's going to exit the acanthion, no different than any of the other waters that you've been doing. This is what it looks like. So you can see the maxillary sinuses well, and the petrous ridges are just in the lower third of the maxillary sinuses so that you can see them nice and open. Here's your nasal septum here, your frontal sinuses, your orbits. Lovely. SMV for sinuses. Oh, look, your IOML is still parallel to the image receptor. Still doesn't change. Your beam is going to be between the angles of your mandible. Still doesn't change. It's the same thing. The difference is that you want to have that nice exposure so that you can see the sinuses. So again, your sphenoidal sinuses are the closest to the center of the image or the center of your cranium. And then your ethmoids are just anterior to the sphenoids right here. And you want to make sure that the mentum is not superimposing the ethmoid sinuses. If the mentum is superimposing these ethmoid sinuses, you really need to extend that neck out of the way. And this is a picture of a transoral where her mouth is open, and that's so gross. I would not do that to my patient, but that's besides the point. What you're doing, you're still positioning the patient just like you would a regular waters. The nose is not touching, so you're still getting that 37-degree-ish angle. But the big thing here is that the mouth is open. And when the mouth is open, you're able to see those sphenoidal sinuses, which are right here, projected into the open mouth. Now notice you see the sphenoidal sinuses. If you had, down here, you can see a little outline of the foramen magnum, and this is the dens. If you had the dens projected into the open mouth, then you're doing more of like an odontoid. So you need to extend the neck upward so that all of that goes downward in just below your mandible. You don't want any of the foramen magnum or the dens up into the open mouth. Also, you can see the maxillary sinuses really well. And when you're doing this, the maxillary sinuses, you're seeing that the petrous ridges are far below the maxillary sinuses here, so that you want to keep them out of the maxillary sinuses. You want to see them free of superimposition. So if the petrous ridges were to be in the maxillary sinuses, you would also extend the neck upward or extend the cranium upward so that it would push these down. So positioning error for the parieto-acanthial projection, which is your waters. Parieto-acanthial means waters. If the petrous ridges are within the maxillary sinuses, you want to increase or extend the cranium or the neck. So the error would be, I'm sorry, I'm making this sound more complicated. The error would be that your head is down too far or your neck is too flexed. So when the petrous ridges are in the maxillary sinuses, so I'll go back, when your petrous ridges are in the maxillary sinuses, that means that you have the head too far down. What you want to do is extend the head or extend the neck so that you can get those petrous ridges out of the maxillary sinuses. Another question. What is the angle between the OML and the plane of the IR for a well-positioned parieto-acanthial projection? Your waters, the angle for your OML is going to be that 37 degrees. If you were to do the modified waters, you'd get the 55-degree angle. Which of the following projections would best detect a fracture of the orbital floor? I talked about that earlier, but you would want the modified waters, that 55-degree OML angle, because what that does is that makes nice round orbits, opens up those orbits so that you can see the orbital floor really well. How much must the skull be rotated from a lateral position to best demonstrate the body of the mandible? That's that 30 degrees for the body. If you wanted to see the mentum, it's 45 degrees. If you wanted to see the rami, it's a straight lateral, or I should say true lateral. How much is the CR angled for an AP axial projection of the mandible? Remember, the mandible was special. It was different for the town if the IOML is perpendicular. 35 for the OML, and then 42 for the IOML whenever we're talking about the mandible. So again, that AP axial town is special for mandible. You use 35 degrees and 42 degrees instead of your usual 30 and 37. So make sure you have that in mind. And that is it. That's your test. You will have an hour to complete it. Make sure you go over the evaluation criteria, or the image critique, I should say, at the back of your chapter. For just facial bones, I did not include anything on your sinus sinuses there. And I did point out everything you need to know, literally question by question, is in this video. So don't overstudy, don't study things that I didn't mention. Make sure that you just kind of follow along with the video. I'm going back. You can replay the video over again. I know it seems like it's a lot of projections, but it's really not. It's whatever is in this video is what is going to be covered on your quiz. I can't stress that enough. Whatever is in this video is what's on your quiz. So anything outside of this video is not going to be on there, okay? And I'm probably going to give you a headache going through all these slides. This quiz review was a little bit more in depth than the last quiz review, specifically because we didn't spend a lot of time on sinuses or facial bones like we did with cranium. So I just wanted to make sure I covered everything appropriately. If you have any questions, please message me. I'm hoping that this video is out early enough so that you have plenty of time to study, and I wish you all good luck. Thank you very much, and let me see if I can exit out of here. We're gonna discard those. All right, guys, good luck, study, listen, and if you have any questions, reach out.